Sir, unmute myself. Sir, unmute me. Hello. Hello,
You are
everyone.
unmuted.
Okay, sir. Thank you. Hello, everyone. Good morning to all respective faculties, delegates, our principal, and dear participants. I, Ms. Priyanka Bandivadekar, Assistant Professor, on behalf of Konkan Jnanpith Rahul Dharkar College of Pharmacy and Research Institute, Karjar, welcome you all to this 3 days AICT sponsored e-conference entitled Global Pharmaceutical Challenges in Drug Development for the Treatment of Cancer and Their Impact in Regulatory Management. For this conference, we got a huge response of participants from various institutes. This is a great initiative taken by our management and our beloved principal, Dr. Mohan Kare sir, to organize this e-conference, where we feel honored to have eminent speakers from academic and pharmaceutical industries with us. And today we have well-known eminent speakers, Dr. Anuradha Majumdar, Dean of Faculty of Science and Technology, University of Mumbai, Dr. Ashok Chandak, Scientific Officer, Department of Atomic Energy, Government of India, Dr. Sunny Garg, MD, DM, Consultant, Head Medical Oncology at Manipal Hospital, Dwarka, Delhi, Mr. Sanjay Bhargav, Executive Director and CEO, In Vitro Diagnostic, New Delhi, Dr. P.R. Gavia, Dean of Academic Program at Institute of Technology, Mumbai. I assure you that this program shall be full of exuberance, tremendous knowledge, and will create some memories for us all. Before going to start with session, I just brief you about our college. Our college is managed by Konkan Jnanpith Trust, which is registered in 1989 under leadership of late Honorable Shri P. N. Darkar. This college is named after late Mr. Rahul P. Dharkar, who was the inspiring force to start this institute. Our B Farm course started in the year 2009, 2006 and Diploma Pharmacy in 2019. The college is approved by DTE, AICTE, PCI and is affiliated to University of Mumbai, MSBT and NAC accredited. The college has excellence record of results and placements year after year. In this pandemic situation, we have organized 1 week online student development program from 18th May to 24th May, 2 days national online webinar on 20th and 29th May, 1 week EFDP and ESDP titled Global Pharmaceutical Entrepreneurship Development Online Webinar Series from 1st June to 7th June. Various competitive programs like online essay competition, online innovative article writing competition, COVID-19 Hackathon 2020, drawing competition, many more. In the period of month May to June for students to give them opportunity to present their hidden talent in this pandemic situation. Lots of faculties, pharmacy professionals, students will respond to these competitions and webinars. Well, now without taking much of your time, we will start our today's session with full of energy. It gives me immense pleasure to introduce our first speaker who having a distinct personality, Dr. Anuradha Majumdar. Dr. Anuradha Majumdar is a well-known teacher because of her knowledge and research work. Madam is working as a Dean of Faculty of Science and Technology, University of Mumbai. Madam has more than 20 years of academic and research experience. She pursued her B Pharmacy and M Pharmacy degree from Nagpur University and PhD from University of Mumbai. She was conferred com- gold medal from Nagpur University for coming first in order of merit in M Pharmacy. Dr. Majumdar's area of specialization is pharmacology. She has been faculty in Bombay College of Pharmacy and her research area is neuropharmacology, metabolic pharmacology, and novel drug delivery system. Her research thrust is on mitochondrial dysfunction in diseases and disorders. She has several patents, publications, book chapters, and international presentations to her credit. Dr. Majumdar has successfully completed a significant number of government sponsored projects, including AICT, DBT, UGC, etc. She is consultant to several pharmaceutical industries such as Shreya Life Science, Marico Limited, Iochem Private Limited, Charak Pharma Private Limited, Hindustan Unilever, etc., and completed various industrial sponsored projects. Recently, her proof of concept on drug delivery system platform has been selected by Cipla Limited and taken up by company for further development. With this short introduction, before hand over to Dr. Anuradha Madam, I request our principal sir to say some few words about today's program. Please, sir.
Thank you, Priyanka. At the outset, I would like to thank Dr. Anuradha Majumdar to consented to be the chief guest to inaugurate this AICT e-conference program, uh, Global Pharmaceutical Challenges in Drug Development, Treatment of Cancer, and their impact in regulatory management. This is today, we will be starting our 41st webinar during this COVID-19 situation. And this one is the sixth major webinar series which has been organized. Thanks to our management and thanks to our team also for making this webinar successful. Today we have a versatile personality, Anuradha ma'am, who was also my colleague at Nagpur, and we are fortunate to have association from Nagpur College of Pharmacy, Professional Association, as well as Indian Pharmaceutical Association, as well as Academy of Innovation and Startup, who have provided us valuable speakers for various webinars. This cancer program, this one is fourth series which we have organized in last 2-3 years, and we have variety of speakers from academicians, from hospitals, from radiology department, etc. And really, for the delegates, it will be interesting to that all the speakers will share their expertise, and you will gain good knowledge, and that too from theoretical aspect, basic aspect to the research level also. So I thank once again to Anuradha madam. I thank all delegates who have registered. All these delegates, because of you, we also feel proud and we are also motivated to bring such webinars from time to time. At the Global Entrepreneurship Development also, we had recorded more than 2,800 delegate registration. And today also for this program, we are having around 800 delegates. Now I request Anuradha madam to inaugurate this e-conference and share a few words, and then she will follow her lecture. Anuradha madam, please.
Thank you, Dr. Kale. I hereby announce that the 3-day ICT sponsored e-conference titled Global Pharmaceutical Challenges in Drug Development for Treatment of Cancer and Their Impact on Regulatory Management inaugurated. And I congratulate Dr. Mohan Kade and his team from the Rahul Dharkar College of Pharmacy and Research Institute for initiating and endeavoring for having this very important e-conference on an area which has a lot of unmet needs. uh, Dr. Mohan Kale, principal, has been conducting such several important seminars and webinars, which is important for society, healthcare, and the pharmaceutical domain. Uh, and as he mentioned, this is 41st in the series of several such webinars and e-conferences which he and his team has conducted over the lockdown period. I'm fortunate to be part of this series of programs on cancer, which is conducted. And in the past twice, I have presented at the Karjat College on areas of cancer. As is evident, the conference boasts of eminent resource persons involved in research of novel drug delivery systems targeting cancer, and also identifying research targets or markers in cancer and in the treatment of cancer. We appreciate the efforts and intentions of Principal Kale and his team. May this consistent good work and endeavors continue. My association, as Dr. Kale said, with Kale sir dates back to my Nagpur days and continues more than 2 decades. Wishes to all the 800 participants, delegates, students, principals who have joined this conference, and my dear colleagues. Around 400 years before Christ, the Greek physician Hippocrates described tumor in the Greek language as cancer, which stems from the Greek word for crab. Our understanding of cancer continues to evolve with with respect to carcinogenesis, prevention, detection, and treatment advancements. While enormous progress has been made in the field of oncology this past decade, the most striking development has been the incredible growth of the field of immunotherapy in cancer. The US FDA has approved immunotherapeutic regimens for around 2 dozen cancer types so far. Many clinical trials which are evaluating immunotherapeutic approaches in cancer has been found to happening in the last few years, which explores improving immune checkpoints in cancer inhibition efficacy. The field of precision medicine has also witnessed extraordinary advancements. Last year, the FDA approved new anti cancer therapeutics, and all of these are molecularly targeted agents. Mumbai city is privileged and fortunate to have the the Actrec, as well as the TMH, the Tata Hospital, uh, which are phenomenal contributors in cancer research as well as cancer treatment. As a city, we are proud to have these two important organizations within our vicinity. Around 2018, WHO has declared that the most important forms of cancer in India and which is very prevalent, is breast cancer, oral cancer, stomach, colorectal, esophageal, ovarian, as well as cervical or uterine cancers. I'm going to discuss on colon and colorectal cancer, which shows a prevalence of around 6.4% globally. Recently, if you've seen, Mumbai University has faced a crisis with the sudden demise of our registrar, Dr. Ajay Deshmukh. In his case also, the cancer was detected very late and he succumbed within very few days after the detection. Very similarly, my highly revered senior colleague, Dr. Aarti Jagtap, who retired from Bombay College of Pharmacy in 2014, last year we lost her to cancer. Again, the detection was quite late. So most of the times we see that cancer gets detected in stage 3 or stage 4, giving very less time for treatment interventions and leading to poor prognosis and therapeutic outcomes. So early diagnosis is of paramount importance for better cancer therapeutics and outcomes. This opens new vistas of research on early diagnostic markers, detections, and robust diagnosis, which can include quantification or detection. And for that, it is very important for pharmacologists and molecular biologists like you and me to identify the pathogenesis and the markers which interplay, which orchestrates the disease generation, which can be detected in the citizens as maybe a cluster of tests or a screening test, series of screening tests, which can be done routinely or annually or biannually, which will help us detect early stages of cancer development. So it is important to understand the pathogenesis of cancer and the various biochemical markers that orchestrate the changes or which are altered due to the pathogenesis of the cancer. I wish the conference all success. It is a very important area for scientific deliberations and discussions. Thank you, Dr. Kale, for inviting me to be the chief guest and also for delivering a technical talk on this subject. It is indeed a privilege for me, and I wish all the participants great scientific sessions and experience during these 3 days of conference. I would now start projecting my presentation. Yes, is everybody able to see my presentation?
Yes, madam, it is visible.
Okay, great. So let's get going with the first session of your e-conference under the aegis of this college. My topic for presentation is therapeutic promise of thrombin inhibition in colon carcinogenesis. Now, this work we had started, I'm not able to change my slides.
There is a PowerPoint presentation in front of you, madam, no? Or you are on
Yes, it
screen?
is.
Okay,
It is
so
the entire screen is open,
yeah,
but
so it is.
should I stop sharing and start sharing
Okay,
again? What should
yeah,
I do?
yeah, yeah. Okay, do it again, madam. We'll check it out.
Okay. Can you see now?
Yes, madam. Now it is visible.
Yes, but the problem is I'm not able to change my slides. Let me
Madam,
just
it showed a certain window at the bottom. What it says? There is a window at the bottom.
window
Uh,
at the bottom. I'm not
something.
able to. Now it
Okay,
can. It is
now
changing.
it's
Is
okay.
it
Yeah.
fine now? Yeah, yeah,
Yeah,
yeah.
yes, madam. Yeah.
Yes. So my topic is basically when we started working on the effect of thrombin. You know, thrombin is associated. Students learn the role of thrombin when we learn about clotting in our anatomy physiology in BPharm program. So what we realized is that there is a close association with excessive thrombin internal clot formation and the pathogenesis of cancer and metastasis of cancer. So there was a Trousseau syndrome which spoke about increased internal clots associated with cancer. And then we came across a paper where dabigatran etexylate, which is a direct thrombin inhibitor, was known to be beneficial in a preclinical model of breast cancer, wherein the scientists from abroad had worked even on breast cancer cell lines and elucidated the action of direct thrombin inhibitors in preventing the spread of or the what you call it worsening of the cancer. So what we did is that, and if you see recently, ladies and gentlemen, even if you see in COVID-19, although here the case is a viral infection, but it has been seen that in many patients, the marker like D dimer, which should be within 50, rises above 400, 500 in patients. And there's a lot of generation of internal clots. So clotting is something which is very closely associated with inflammation and other downstream cascades of different pathways. So this is what drove us to to explore the potential of direct thrombin inhibitors in one of the most a cancer form, that is colon or colorectal cancer, which is detected very late and which spreads very fast. So towards the after the stage 2. So this is the Virchow's triad, which spoke about internal clots and thrombosis, deep vein thrombosis, an increase in that, coagulability related to worsening of cancer and pathogenesis of cancer. So coming to the form of cancer which I have worked on, colorectal cancer is the third most common cancer in the world. And if you see the current 2018, you can see that estimated that 4.2 to 3.2 in males and females in 100,000 patients suffer from colorectal cancer. And remember, colorectal cancer is also very much linked to, especially in the Western countries, to lifestyle, especially food. So coming to another aspect which I'll be covering in my presentation, due to paucity of time, Dr. Kale just spoke to me. He said I have around 50 minutes time so that we can take question answers for 5 to 10 minutes. So as many of you all are aware, one of the important happenings in cancer is the conversion, is the EMT phenomena, that is epithelial mesenchymal transition. Epithelial cells, as you know, are lining cells, covering cells. They are known to be morphologically tightly packed. In cancer, it has been seen that epithelial cells slowly get transformed into mesenchymal cells. And the mesenchymal cells are the cells which, like we see in connective tissue, are loosely packed. So this allows a cluster of cells like an emboli or with thrombus, some cancer cells to migrate downstream, okay, leading to metastasis and secondary growth. The main markers of epithelial cell surface, what we had characterized, was E-cadherin. So E-cadherin is an indicator of epithelial cells. When it gets transformed to mesenchymal cells, the markers which is seen predominantly in the cell is N-cadherin. Reasons that the cancer cells, the cluster, the solid tumors, it will aid in angiogenesis. It will also aid in metastasis. So this is an important phenomena which is encountered in most of the solid tumors. So now coming to the thrombin pathway, if you see this pathway, if you see on the left hand side, the thrombin which acts on the protease activated receptor 1, as you know, thrombin is something which is promoting clot formation, the internal as well as external clot, for intrinsic and extrinsic clotting process. In the intrinsic clotting process, the thrombin triggers a cascade of changes inside the cancer cell, which leads to overexpression and triggering of the ERK MAPK pathway, the mitogen activated protein kinases, which are known to then activate one of the very important marker which is seen in cancer, that is vascular endothelial growth factor. You and me all know that will trigger angiogenesis, formation of new blood vessels, and will give nutrition and oxygen to the newly growing cancer, okay, and leading to more survival and proliferation of the cells and sustenance of the cancer. So this is one pathway which we targeted in our study. So what we saw is that the potential for anticoagulant therapy to retard tumor progression, and like for example heparin, low molecular weight heparins, warfarin, etc. But you know, these anticoagulants have to be modulated, need a lot of therapeutic monitoring while being given. So we thought about, and you know, the injectable preparations, we thought about working on direct thrombin inhibitors. And then Bombay College of Pharmacy and my laboratory, we struck a MOU with Boehringer Ingelheim, Germany, for a material transfer agreement for a drug which was still under patent, that is dabigatran etexylate, which is a direct thrombin inhibitor. So, what is the advantage of dabigatran? It has predictable response, wide therapeutic window. It fixed dosing, no titration required, unlike the other anticoagulants, minimal drug-drug interaction, etc. So, this was the reason that we selected dabigatran and went ahead with it after we received the consignment from the Boehringer Ingelheim. So this was the research hypothesis. We hypothesized that dabigatran etexylate, which is a direct thrombin inhibitor, would inhibit thrombin, and in the process, the downstream cascade, which is ultimately stimulation of MAPK, ERK, MAPK, and increased transcription of vascular endothelial growth factor, would be inhibited. mTOR, which is coming through the AKT pathway, the P10 pathway, that also there were some reports. Remember one thing, what we have seeing in COVID as well, hypoxia or low oxygen triggers the thrombin pathway. And as you know, in the case of COVID viral infection, it infects the lungs primarily, the upper and lower respiratory tract, and that leads to hypoxic state. Sometimes the patient's dissolved oxygen goes below 80% and maybe further down. So that triggers, again, probably that's one of the reasons that during the acute phase of the infection, also we see D-dimer expression, which is a marker for internal clotting, increasing. Similarly, D-dimer expression is also increased in many forms of cancer. So this was our hypothesis. And as you know, hypoxia in a rapidly growing solid tumor is encountered because the rapidly growing tumor needs more oxygen. So this was our basically our grouping. So we had the saline control group. We had 72 rats, other than the saline control groups, which were randomized. Dimethylhydrazine was used to induce chemically colon carcinogenesis. And we had a positive control group, which was given only DMH, the dabigatran etexylate treated group, 5-fluorouracil, which is standard of care in colon cancer, and a combination group wherein we gave both dabigatran etexylate as well as 5-fluorouracil. And we did a lot of standardization because it was the first time that we were embarking in a research where we really wanted to see the timelines, of changes and generation of pathogenesis due to DMH in the animals. And we did extensive histopathological study during our standardization phase of these research. So here I think it's very crowded, but you can just see this. These are the groupings, and you can see primarily the dosing for dabigatran etexylate was selected based on one of the preclinical studies, as I said, which was done in vivo as well as in vitro and animal in breast cancer cell lines, and on a model of breast cancer. And based on that, we decided on the regimen, which was weekly, daily, twice a day, except the weekends, where the dose was hiked from 45 mg per kg per oral to 60 on Saturdays and Sundays. 5-fluorouracil was followed as per the intraperitoneal, and the combination had both the dabigatran etexylate in the same regimen and 5-fluorouracil. So this was this. And if you can see, during the study, we also would follow for occult blood, since the thrombin inhibitor, we didn't want internal bleeding, which was very evident in the fecal. If there is a bleeding, you'll see blood in that, or traces of red in that. So which was followed diligently throughout the assay. There were several biochemical estimations done, and colonic homogenates were used for estimations. The colonic tissue, water content, gross morphology, fecal occult blood, as I told you, the food consumption, anthropometrical parameters, etc. And we did some ELISA tests and RT-PCR based studies to estimate the markers. So this is what I just said. This is the same thing. And for biochemical estimations for vascular endothelial growth factor and ERK MAPK estimations, we used ELISA. While for the epithelial mesenchymal transition parameters, we use RT-PCR. So this is what was done. So across the parameters assessed was anthropometrical parameters, body weight, and all the indices, food and water consumption, gross morphology of the tissues, colonic edema in biochemical estimations, VEGF, ERK, MAPK, and the EMT parameters using PCR, as I said. And for immunohistochemistry, we performed E-cadherin and cadherin estimations. Using PCR, we quantified E-cadherin and cadherin, the twist protein, which is expressed by the twist gene, which also gets expressed excessively when the tumor proliferation increases, and it is linked to more growth and proliferation of tumor, and the mammalian target of rapamycin, the mTOR, this was also estimated. So this is about the anthropometrical parameters. So as you can see, the DMH group, as you can see, is affected. So the rat weights were declined because of the carcinogenesis, and it improved with the treatment. You can see the group is a cross, which is a combination group of dabigatran etexylate with 5-fluorouracil. We have to understand here that DE cannot be a standalone treatment for any form of cancer. It has to be an adjunct to prevent the thrombosis associated acceleration which happens in cancer because of internal clot formations, as also predicted by increased metastasis and secondary growth of the tumors. So this is regarding the food and water consumption, and as is evident that this improved the activities, that is the combination, helped in these parameters. This is the colon gross morphology, and as I told you, we did a lot of study across the timelines. We had termination time points from the 6th week to the 16th week. And I would like you to take note of the 16-week DMH group, that is a positive control. At the end, where the yellow arrow is there, the last panel, the longitudinal panel, you can see the colon polyps being formed. So actually, we did not go to the stage where, we wanted to see the carcinogenesis. We wanted to see the progression of the disease. So here you can see in week 16, the development of the polyps, which is a carcinoma, and which is evident due to the DMH exposure of this group of animals. Colonic edema, as you see, the colonic edema increases in the positive control group, which is dramatically less in the combination where we have administered both 5-fluorouracil intraperitoneal as well as given the regimen of dabigatran etexylate. This is the VEGF expression, which can signify the angiogenesis in the growing tumor site. And you can see that VEGF expression is reduced over time. You see the week 8, not very, very clear, although there is a decline with the treatment interventions, both per se DE or per se 5-fluorouracil, and it is much improved with the combination, and that persists and is more pronounced by the time that the study reaches the 16th week. This is the biochemical ELISA testing of ERK, MAPK, which, as you know, is a very important marker for tumor proliferation. And here also you can see that in the positive control group of only DMH, where you have the checkered column, you can see in the checkered column there is a phenomenal increase and very noteworthy increase in the levels of MAPK, and which is declined in the groups in the per se groups of DE as well as 5-fluorouracil, and it is more pronounced in the group which has been given both DE as well as 5-fluorouracil. This is coming to, I was talking about the EMT parameters. So we did both, we did immunohistochemistry based analysis as well as we use RT-PCR. So here you can see the expression changes. E-cadherin in the positive control group is not there. That means epithelial markers in the colonic tissue, the epithelial cells have transformed to the mesenchymal cells. And we can see that the change is prevented in the treatment intervention groups, and also that it preserves the morphology of the epithelial cells. So when the epithelial cells persist, what happens is, and the transformation to mesenchymal morphology doesn't happen, what happens is it prevents metastasis. It prevents clusters of the growing tumor to come out like an emboli and reach to other sites for further growth and secondary growth. So you can see N-cadherin expression. N-cadherin expression is the highest in the positive control DMH group, and it reduces to a large extent with the treatment interventions, and is the best with the combination therapy. This is a twist gene expression, which also increases when tumor proliferation is high, and which further actually promotes further cell division, and mTOR expression is reduced. So you can see twist expression and mTOR expression is reduced by the treatment interventions with dabigatran etexylate and 5-fluorouracil, and the combination shows a better response. This is, as I told you, the colorectal cancer. We wanted to see the progression, and this is the DMH group, the positive control, where you can see marked distortion of the morphology, and re-engineering of the morphology of the colonic wall, which you can see in the week 16, very pronounced change, which is evident and which is known to be elicited by dimethylhydrazine chemically. And this is the histopathology in week 8. This is DMH induced. You can see that various changes associated with the mucosal lining. Okay. So this was what I was telling you about, the pronounced histological study which we have done over the weeks to quantify and categorize that, yes, what was the extent of morphological change and the re-engineering of the wall of the colon. And this is what we saw in immunohistochemistry. I would like you to see the change in expression. So E-cadherin is the highest, which we have seen in the combination group, and it's the lowest. In fact, there is maximum conversion of the epithelial cells and its transition to mesenchymal parameters in the DMH group, which you can see over the 8th week, 12th week, and 16th week. And here with the final combination, you can see the expression of E-cadherin, that means retention of epithelial parameters, in the week 12 and week 16. Histochemistry of N-cadherin, which is a marker for mesenchymal transition. So here you can see the mesenchymal transition is the maximum in the DMH group, and it is minimum in the groups where there has been therapeutic intervention of especially the combination. So this is sort of gives you the E-cadherin percentage positivity, the sample which was used, which was the colon, and the N-cadherin percentage positivity. So as you can see in the with the intervention with dabigatran etexylate and 5-fluorouracil, we saw minimum conversion or transition of the that is epithelial cells to mesenchymal cells, as is indicated by retention of percentage positivity of E-cadherin in the animal colons which were treated by these two drugs. So, in summary and conclusion, what we saw is that in using dimethylhydrazine as an inducing agent, we saw gross colonic changes, cancer cachexia, which you see, loss of weight because they stop eating, because of the distress, colonic edema, histopathological changes, increased expression of VEGF and mitogen activated protein kinase, decrease expression of E-cadherin in colonic tissue, increase expression of N-cadherin, which is showing increased EMT transition, increased twist protein and mTOR protein, which are expressed. As you can see, they are all part of the pathway, which ultimately leads to cancer proliferation, increased proliferation and sustenance. And so DMH basically caused EMT transition in the animal's colonic tissue. While we are concentrating, our study was mainly to hypothesize that dabigatran etexylate per se will have some effect because thrombin is involved in the pathway of EMT transition, and also how it can work as an adjunct therapy with drugs of choice like 5-fluorouracil in the case of colon or colorectal cancer. So we saw that DE induced reduced the change, the re-engineering of the colonic tissue, improved the body weight of the animals. They also reduced the colonic edema, brought about positive histopathological, it prevented the negative histopathological changes, reduced the expression of vascular endothelial growth factor and MAPK, and improved and helped retain E-cadherin as a marker, which showed that lesser number of epithelial cells got transformed to mesenchymal like features, and that was a very important outcome which we saw in the result. We also saw decreased expression of the twist and mTOR protein. So these are the highlights. I did not give all the discussion part because of paucity of time, so that we can discuss a bit after my presentation. So what is the translational value of this research? Once we completed the research, we had given the entire report as per the requirement to Boehringer Ingelheim, and they also assisted us in our publication. And now, as you know, the drug is off patent. So the proof of concept generated by our research showed that dabigatran etexylate, a direct thrombin inhibitor, is effective in a murine carcinogen-induced colon cancer model. It also showed additive effect with the standard of care 5-fluorouracil. It is beneficial over the different progressive stages of colon carcinogenesis. It can be an early predictor for aberrant crypt foci, which is visible over colonoscopy. See, many times patients of colon, who have developed the pathogenic changes and which can lead to a full-fledged colon cancer, which can start from colonic inflammation. So, or, sometimes patient misjudge that if there is a bleed in the fecal content, it might be due to hemorrhage or piles. So it's very important that the colonoscopy is done. And what we have seen that the aberrant crypts, which are formed during the early stages, can be a very good marker for diagnosing colon carcinogenesis, and probably will have improved the prognosis and treatment outcomes. And this can be detected by colonoscopy. In clinical settings, early stage colon cancer, establishment of complementary treatment to existing chemotherapy. So if the colon carcinogenesis is detected early, especially people who have inflammatory bowel disease, or you have colonic inflammatory issues, or see specks of blood in there, they should try to dispel and find out whether there is any changes in the morphology, and colonoscopy can be a good way of doing it. The publication this is a publication which is from I would like to thank my PhD student Prajakta Sangole, who has done this work in her PhD program, and she is now currently in Canada. And the therapeutic promise of dabigatran etexylate, an oral direct thrombin inhibitor in a preclinical model of colon carcinogenesis. This was published in 2018. When the work got completed, we took permission also from Boehringer Ingelheim, Germany, and we got permission, and then we published our work. This was presented again when the work was 3/4 complete, and we were trying to collate and analyze our data. The project had gone to Amsterdam for the European Cancer Congress 2017 and presented this work. And if you see today, I would like to say that, even if you see in COVID, anticoagulants are being used. Some people are trying even to use aspirin. In Europe, in the Western world, aspirin was prescribed, especially if you can have enteric coated aspirin to prevent the thrombosis, which is very clearly evident in many patients of COVID-19. And when the patient is hospitalized, is probably under oxygen treatment, then probably they can try out low molecular weight heparin and others. So we cannot rule out the important role of thrombin and its inhibition in treatment of several disorders, be it cancer diseases, whether be it cancer, be it COVID-19 infection and its ramifications and manifestations. There are so many collateral, changes other than the lung damage which it does, right, which is inflicted by the COVID infection. So we extend sincere thanks to University Grants Commission for funding this project, and to Boehringer Ingelheim for Germany for providing us the dabigatran etexylate and its vehicle natrozole to us. Thank you very much for patient hearing. I can take a couple of questions before the next speaker comes in.
Hello, madam.
Yeah.
Uh, have you reached on the StreamYard now? Okay. So here is the first question from the survey. Is it visible, madam?
I'm trying to just get back to the.
Yeah. Hello, madam.
Yes. Yeah. Please tell me. Yeah. Yeah. I'm
Yeah.
good now.
Yeah. So here's the first question. From yeah. So cancer and how it get detected.
Colonic inflammation can all it can be first signs can be indigestion, which is, see, it's very important that I saw in the case of our registrar sir as well. He could not detect. We have to. You have a normal, like we in Ayurveda they say, you have a typical type of digestive pattern. There are any changes in that, you're not able to digest, let's say, certain forms of food, maybe carbohydrates or fats, or you get inflammatory burning sensation like you get when you get acidity or like a heartburn, right? Or you get blood in the feces, those can be the signs that something is wrong. It may not be colon carcinogenesis or cancer. It might be a inflammatory bowel, it can be an ulceration also. But we need to evaluate through proper diagnosis to find out whether it is just acidity or ulceration or inflammation of the GI tract, whether it is the inflammation of the colon, okay, or is it a hemorrhage or a pile. So it has to be, categorically evaluated what is causing the distress associated with the GI tract. So the first morphological change, as madam asked, is the formation of aberrant crypts, in the wall of the colon, which further then undergoes morphological changes. And one of the morphological further downstream changes would be EMT transition. Did I answer your question?
Okay,
Yeah.
madam.
What are the drug interactions between thrombin inhibitors with no interaction between thrombin inhibitors and 5-fluorouracil? That has not been reported also, and not been because this Boehringer has worked on it, because it is trying to pitch this product for several conditions. So that has not been encountered. No drug-drug interaction. But yes, whenever you are using dabigatran etexylate, or even if you're using anticoagulants like warfarin or you're using heparin, you'll have to monitor. You have to calibrate and titrate, because you don't want excess of the molecule or excess drug, because then the opposite will take place. It can lead to hemorrhage, right? When you are preventing thrombin excessively, it can lead to hemorrhage. So we have to be very alert that there should be. That's the reason we did that occult fecal occult blood test, to see whether our dose was correct and did not lead to. I am not aware of the cloning of this plasmid. Sorry, Rasi, I'm not aware of it. I will not be able to tell you on that. Aspirin in colon cancer, no, because that is more of a platelet aggregation inhibitor. But aspirin will certainly work in it will work in cases like COVID, when you are starting to get, let's say, you are starting to lose your sense of smell of taste, which is very predominant in patients who are just starting to get COVID. You should start with Ecosprin low dose, I feel, because it is 75 mg should do. At least your blood will be thinned in this. So classically till now aspirin not prescribed, because aspirin, as you know, has a propensity to cause ulceration. That's the reason we use enteric coated preparations. So these dabigatran etexylate, for that they've also made an antidote kind of a thing. So if the patient is showing a sign of hemorrhage, okay, under medical supervision, they have made an antidote or an antagonist which can actually buffer the excess dabigatran, so as to have the right balance of preventing internal clots but not leading to hemorrhage. So companies like Boehringer, they are very thorough in their research, and they have really worked out the exigency plans if there is any side effects or toxicity associated with the drug. Photodynamic therapy, yes, certainly there are a lot of studies going on photodynamic therapy in cancer. I'm sure you may have. I think some scientists and doctors are joining from Tata Memorial Hospital. They would be telling you about radiation therapy, and if at all they are using photodynamic therapy. I think my next speaker himself would be talking about. He's from TMH. He was there. We were part of the team in the last conference, also arranged by Dr. Kale and his team. And I think they are going to give you a good insight into what they are using in actual therapeutics, and how photodynamic therapy is at all used, if it is, and how it is used in the radiation medical division of Tata Memorial Hospital.
Okay, madam. Now we will take a last question and then we will conclude our session.
How can we find sooner whether cancer treatment is working? That's the reason we say about markers, markers to be identified. When I gave my speech, that markers have to be identified, which play an important role in orchestrating the pathogenesis of cancer, be it colon cancer or any other form of. Very similar to like how HCG is used in ovarian and other forms, you see. So if we know what are the main orchestrating markers and proteins in the pathogenesis, we will know which are the players in stage 1, stage 2, and how it is further changing, whether there is overexpression, underexpression, it is upregulated, downregulated. So on that basis it is important. But for colon cancer, I think colonoscopy, the morphological changes like aberrant crypt formation, which can be caught in colonoscopy, can be a very good early diagnostic method. Because what happens, we've seen in colorectal and colon cancer, by the time patient comes, realizes of the discomfort, it's many of the times it's stage 3, maybe stage 4. I think my colleagues from Tata Memorial Hospital can be a better this in telling you all that, and giving you a brief on what stages they encounter their patients in. So it's very important that, like we have a battery of tests, a diabetic goes every 3 months and gets his fasting postprandial glucose tested, HbA1c tested at least 6 monthly or a yearly. Very similarly, we should have a battery of tests, simple, not very expensive, doable tests, which is screening tests, which will tell us whether key markers in which can be early sign of cancer generation, maybe colon, maybe breast, maybe uterine. And if those can be detected, and a screening method, then it will save so much of trouble for the patient, because the patient early on will be forewarned. Not only patient will be forewarned by these markers or changes, doctors can take early on steps and interventions which will improve therapeutic outcomes in cancer, and will entirely change the statistics of in the treatment of cancer. So was that the last question, Kale sir? Was that the last question?
Yes, madam. It was the last question. Now we will conclude the session.
Thank you,
As
madam, for accepting our invitation and for your
now,
valuable
the
talk
second speaker is
on.
inviting.
Thank
Yeah,
you very much, Priyanka, and thank you, Ajay, for your technical support. And the greatest thanks goes to Kale sir, Dr. Mohan Kale. He has been my very senior colleague, and I respect him a lot. And he has been prolific and dynamic in Nagpur, and he's as equally, or rather, more dynamic and prolific in Karjar. And I really
Thank you, ma'am.
appreciate his endeavors, and it has been consistent, and he has also involved teachers from the Rahul Dharkar College of Pharmacy, that cultivates your research acumen also, and it will motivate you all to take part and participate in research per se, as well as cancer research. Thank you
Thank
very
you.
much.